تمام. I'm going to talk about atrial fibrillation first, classification, pathophysiology, etiology, presentation, workup, and management. First of all, I'll just discuss a few cases with you and then go to the topic. First patient, he's 61. She's 61, female, seen in March 2021. She's non-diabetic. She was obese, underwent bariatric surgery in 2020, improved obstructive sleep apnea post-surgery, and she was not using CPAP after that. She had mild to moderate coronary artery disease, hyperthyroidism with all complications, then developed iatrogenic hypothyroidism post-partial thyroid resection. She was referred to cardiology clinic with a new onset atrial fibrillation 2021, started by the primary physician on Concor and apixaban, rate-controlled atrial fibrillation, but she was always complaining of fatigue and tiredness. Anyone want to add any comment about the scenario? Any questions? Okay. Her echo in June 2021 showed moderate dilated LV, mild eccentric hypertrophy with multiple regional wall motion abnormalities, moderate reduced ejection fraction, and diastolic dysfunction. So she was taken to coronary angiogram, showed multiple lesions, underwent mid-LAD PCI, and started a full anti-failure therapy. Despite all of this, her ejection fraction didn't improve and her symptoms didn't improve. Although her Holter showed heart rate was always under control with average heart rate 65, but in atrial fibrillation. At this stage, you see that patient has multiple comorbidities with high CHA2DS2-VASc score. The primary physician decided to go for rate control management, but the patient was not feeling well all the time, including tiredness, fatigue. They thought about, at the beginning, it could be because coronary artery disease, but even after correction, ejection fraction didn't improve and symptoms didn't improve. So at this stage, better to think about rhythm control strategy. So she underwent successful TE guided cardioversion, and her ejection fraction improved to 51% with complete resolution of her symptoms. She was clinically doing well. So to maintain the sinus rhythm as much as possible, she underwent AFib ablation and pulmonary vein isolation in January 2023. She was doing well in sinus rhythm, but regarding her, I mentioned that she has obstructive sleep apnea. Unfortunately, she was admitted in February with respiratory failure. She was not using CPAP, and according to her, she was doing well without it. But during that admission, I tried to cardiovert her, but unfortunately, didn't. No voice? Hello? Anyone can hear me, or please let me know. Okay. Okay. So there is voice. So she underwent successful ablation. After that, developed respiratory failure, required CPAP again. After 1 month on continuous CPAP every night, she was reverted to sinus rhythm, and currently she is doing well with no symptoms. So in some patients, it's really important to maintain sinus rhythm. Not everyone will fit for rate control strategy. Not everyone will fit and rhythm control strategy. And the decision should be taken in consideration with the patient and all the comorbidities. This was her procedure. You can see the pulmonary veins. And what we usually do, try to electrically isolate the pulmonary veins from the left atrium. Second case, 39 years old male patient, medically free, had episode of palpitation and syncopal event, admitted in another hospital, and started anti-epileptic medication and Concor. You can see that the presentation of the patient sometimes is vague, and sometimes they they commit the patient for unnecessary medication. Like this patient, he developed syncopal event, and according to the witness that there was uprolling of eyes, so they labeled him as epilepsy and started anti-epileptic medication. His ECG at that time was atrial fibrillation with faster ventricular response. The patient, after starting anti-epileptic medication, didn't improve, and he had recurrent palpitation with easy fatigability. And I saw him in December 2022. ECG was sinus rhythm with echo was completely normal EF, normal valves, and atria size and volume was normal. I started him in flecainide to maintain him in sinus rhythm, but it was difficult for him to get the medication. It's not really available everywhere. And I decided to go with the patient to go for a rhythm control strategy, and he underwent AFib ablation. After that, he was evaluated by neurology since there was no symptoms, and all the medication stopped, including anti-epileptic medication. He's doing well with no symptoms right now. Next patient, he's 49 years old, male patient, first time seen in 2019. Smoker, hypertensive, obstructive sleep apnea, seizure disorder, referred for recurrent syncopal event. It was started with shortness of breath, profuse sweating, dizziness, then loss of consciousness for a few seconds. When I saw him, his ECG was normal, Holter was completely normal, and even by the primary cardiologist before referral, all the workup was normal. So I decided to go for loop recorder just to see what is the rhythm when he developed these symptoms. Is it cardiac or non-cardiac? And it was atrial fibrillation. It was documented with at the same time with the symptoms. Of course, you don't, if you want to diagnose the patient, the patient should develop the symptoms, and you check this the ECG during symptoms. So the patient was labeled as atrial fibrillation and started an apixaban since his CHA2DS2-VASc score is high, and Concord. The patient still, he had recurrent symptoms, not like before, but he had recurrent symptoms. I, of course, encourage lifestyle modification and compliance in CPAP. Before you decide for rhythm control strategy or any ablation for his atrial fibrillation, he has to, the underlying risk should be modified as much as possible, especially obstructive sleep apnea. So AFib ablation and pulmonary vein isolation done. Currently he has no more symptoms, but of course, he is maintained on NOAC since his CHA2DS2-VASc is high. So what is the classification of atrial fibrillation? Paroxysmal atrial fibrillation, which is self-terminating. Persistent atrial fibrillation if it lasts for more than 7 days and or require electrical or pharmacological medication. Long-standing persistent of more than 12 months. Permanent atrial fibrillation if the patient and the physician, they decide not to commence rhythm control. The first diagnosis of atrial fibrillation can be anything, can be at the first time paroxysmal, can be persistent, and can be long-standing persistent. When to say paroxysmal atrial fibrillation, it's recurrent when the patient at least has 2 or more episodes. If recurrent atrial fibrillation terminates spontaneously, it is paroxysmal. Some patients with paroxysmal atrial fibrillation, typically they are young, and most of the time they have no underlying medical conditions, and they usually have active foci within the pulmonary veins. That's why it's important if the patient go as early as possible for pulmonary vein isolation. Paroxysmal AFib can progress to persistent, and aggressive attempt to restore the sinus rhythm is really challenging. Persistent AFib, if it is recurrent, if the recurrent AFib is sustained, it is considered persistent, irrespective of whether the arrhythmia is terminated by either pharmacologic therapy or electrical cardioversion. It may be either first presentation or the result of recurrent episodes of paroxysmal atrial fibrillation. It can also include the patients with long-standing AFib in whom cardioversion has not been indicated or attempt, often leading to permanent atrial fibrillation. Most patients with persistent, they have underlying like structural heart disease, congestive heart failure, atrial fibrillation secondary to ischemia, thyroid disease, and of course, if the persistent AFib is uncontrolled with rapid ventricular response, most of the time will lead to atrial cardiomyopathy and ventricular failure. Permanent atrial fibrillation is recognized as the accepted rhythm, and the main treatment goals are rate control and anticoagulation in patients when you say that long-standing persistent atrial fibrillation. And although it's possible to reverse the progression from paroxysmal to persistent and to long-standing, and of course it's challenging, you can use the medication or cardioversion or the ablation procedure. Lone atrial fibrillation, we try to avoid this term, but usually the younger patients without structural heart disease who are at lower risk for thromboembolism, the definition of lone AFib remains controversial, but it generally refers to paroxysmal, persistent, or permanent in younger patients than 60 years of age with normal echo. What is the pathophysiology? There is multiple theories for atrial fibrillation, but there is always electrical remodeling, structural remodeling, and contractile remodeling. They usually believe that there is autonomic focus and or multiple wavelets. These multiple wavelets hypothesis propose that fractionation of wavefronts propagating through the atria result in self-perturating daughter wavelets. In this model, the number of wavelets is determined by the refractory period, conduction velocity, and mass of atrial tissue. Increased atrial mass, shortened atrial refractory period, and delayed intra-atrial conduction increase the number of wavelets and promote sustained atrial fibrillation. From this theory, that people in the studies, they thought that with early intervention, when the paroxysmal atrial fibrillation and the still normal heart, the success rate of the procedure of AFib ablation will be more successful, better than wait, and the remodeling already started, the result of the procedure regress. So there is an atrial fibrillation, there is electrophysiological factors, shortening of the refractory period, ionic channels, connections, genetic influence, hemodynamic factors, increase in intra-atrial pressure, structural factors, atrial fibrosis and inflammation, modulatory factors, alteration in autonomic tone, triggering factors, atrial and ventricular extrasystole atrial tachycardia. What is the risk factors? Genetic, race, obstructive sleep apnea, smoking, obesity, sedentary lifestyle, endurance exercise, and of course, advanced age. They consider it age-related also, atrial fibrillation, diabetes, hypertension, alcohol intake, myocardial infarction. There is a triggers, there is structural changing, and of course, the patient, once he have atrial fibrillation, he will be in the circle. More remodeling, more structural remodeling, then reduce systolic function, heart failure, and it will be difficult to manage this patient at this stage. What is the etiology? As I mentioned, atrial ischemia, inflammation like myocarditis, pericarditis, non-cardiovascular respiratory causes like pulmonary embolism, pneumonia, alcohol, drugs, endocrine like hyperthyroidism, subarachnoid hemorrhage, stroke, genetic factors, and advanced age. Why it's important to manage atrial fibrillation? It carries a lot of mortality and morbidity, and epidemiology. The number of atrial fibrillation discovering worldwide is increasing and is associated with higher rate of ischemic stroke and up to 5% per year. And that's why it's better to manage the atrial fibrillation as early as possible. What is the presentation usually? The presentation is very variable, sometimes with syncope, sometimes with shortness of breath, sometimes they present with heart failure as first presentation. Up to 90% of episodes may not cause symptoms, but patient may experience wide variety of symptoms. And what is the workup? First of all, especially nowadays with the increase in the number of smart applications and tools like Apple Watch and others, Usually the diagnosis, many patients, they come, they say that they have atrial fibrillation. We don't take it seriously. You have to see yourself that the rhythm is atrial fibrillation. Documentation is very important. So when you see ECG, what are you looking for? First of all, a regular rhythm. RR interval is irregular, absence of P wave. Sometimes you can see there is ECG changes suggestive of coronary artery disease, myocardial infarction. Maybe you can see Ashman beats, which is apparently conducted beats. And sometimes you have to check for left ventricular hypertrophy, which is common in atrial fibrillation, bundle branch block, interventricular conduction delay, and QT interval. All of this, you have to look at it when you see ECG with atrial fibrillation. For example, I need some contribution. What do you think about this ECG? Do you think this is atrial fibrillation? Please unmute your mic and participate. Anyone? Okay, so this is not atrial fibrillation, although the rate is irregular, but you can see that especially in V1, there is nice P wave. So this is atrial flutter. So some patients, some physicians, sometimes the ECG is reviewed by primary healthcare or others, it's not very clear for them, and they label the patient as atrial fibrillation, and you receive the patient as atrial fibrillation. It's very important to diagnose the patient correctly. So this is atrial flutter, true. What other investigations that you can do? Lab work like electrolytes. For example, the patient may have electrolyte abnormalities. Echo, of course, to check for valve, to label the patient valvular or non-valvular atrial fibrillation. Check the atrial size and volume, ejection fraction. All of this is very important. You may need to do a transesophageal echo if you are planning to do cardioverge, to check for left atrial appendage thrombus. It's very important if you are planning for it. CT and cardiac MRI. Nowadays, the need of CT and cardiac MRI is increasing because it will show you the anatomy of the left atrium. It will show you the pulmonary veins nicely. There is a lot of studies, they are discussing the fibrosis that is discovered in cardiac MRI, whether it is it's important to ablate these areas or not, but it's still there is no strong evidence. Others, Holter stress test, especially if when the patient comes to your clinic in sinus rhythm, and you need to document atrial fibrillation. All of this workup, it has to be done. Loop recorder, like the patient that I presented, sometimes loop recorder is important, although it is little bit you have to do the procedure, and some patients, they may not like it, but it's still important to know the diagnosis. Electrophysiology study, sometimes at the same time when you go and do AFib ablation. Why it's important? Some patients with AV-NRT, some patients with AVRT, some patients with pre-excited atrial fibrillation. The underlying cause is they have a pathway or AV-NRT. So when you ablate the pathway, they will not have atrial fibrillation. So the patient will not go for AFib ablation, only simple ablation procedure. That's why it's important to see all of this, especially if you have young patients. What is the consequences of atrial fibrillation? Why it's important to manage the patients properly? Thromboembolism, number one, stroke, increased risk of thromboembolism with atrial fibrillation, recurrent hospitalization, and of course, recurrent hospitalization means a lot of money. Reduced quality of life. Sometimes, like the patients that I presented, fatigue, loss of stamina, and especially for young patients, it's really difficult to walk around with all of these symptoms. Number of mortality increase by twofold in patients with atrial fibrillation, sudden death, and heart failure, hypertrophic cardiomyopathy, impaired hemodynamics, loss of arterial kick, irregular ventricular contraction, heart failure, tachycardia-induced cardiomyopathy. I will not go over the guidelines, all of it, because you can go and read it. But it's important, just there is a major difference in stroke risk stratification between the American and European guidelines. All of us, we have just to follow Chad's VASC score, and congestive heart failure 1 point, hypertension 1 point, age more than 675, 2 points, diabetes 1 point, stroke, TIA, thromboembolism 2 points, vascular disease including myocardial infarction, peripheral vascular disease 1 point, age 65 to 74 1 point, female sex 1 point. So the American guidelines, if it is 0, no antithrombotic therapy, 1, no or antithrombotic therapy. It depends between the physician and the patient decision. And if it's more than 2, the patient should go for the antithrombotic therapy. But the European guideline, even if the patient has 1, just go for oral anticoagulation immediately. There is no question between whether you give or you don't give. So the initial step towards the therapeutic decision in the determination of atrial fibrillation, duration, classification, onset date, discovery of atrial fibrillation, frequency, precipitating factors, symptoms. You have to know about if there is LV hypertrophy or not, pre-excitation, bundle branch block, prior MI. All of this is very important before you decide for medical therapy, and choosing the medication itself is very important to know these informations. QT interval, all of the anti-arrhythmic medication can affect QRS duration and the QT interval, so it's very important to know baseline ECG and the intervals. So it is either rate control or rhythm control. Each patient, you have to assess Chad's VASC score, Chad's VASC score, you know the etiology, and then you choose the rhythm or rate strategy. So if you decide for rate control strategy, target ventricular rate control in the absence of accessory pathway can be obtained by AV nodal slowing drugs. Initial target ventricular rate is less than 100 beats per minute at rest. And if the patient is still complaining, you can try strict rate less than 80 at rest, less than 110 during moderate exercise. This is the usual medication that we use, especially in ER: Zumulol, metoprolol, propranolol, diltiazem, verapamil. Sometimes in some hospital, depends which is available, but this most commonly medication is used. What about rhythm control strategy? Immediate electrical cardioversion should be considered in AFib causing hemodynamic instability without considering the duration, classification, and even if the patient, you don't know if the 48 hours, more than 48 hours, the anticoagulated or not anticoagulated, you just go for cardioversion if the patient hemodynamically unstable. Immediate cardioversion is also recommended for AFib involving pre-excitation. If the patient has pre-excited AFib, the patient should go for immediate cardioversion because the risk of ventricular tachycardia, ventricular fibrillation. If the patient is hemodynamically stable, you can think about pharmacological cardioversion. So if the patient has recent onset atrial fibrillation with rapid ventricular response, hemodynamically unstable, you just go and cardiovert. Sometimes you need to cardiovert the patient if you decide to maintain sinus rhythm. But of course, if it is more than 48 hours, you have, or unknown duration, you have to do it under guidance of TEE to rule out left atrial appendage thrombus, and you have to decide also about anticoagulation. Don't forget contraindications. If the patient has thrombus, if there is in the presence of digitalis toxicity, severe electrolyte imbalance, if the patient had recurrent cardioversion and with short recovery time, so it's better to avoid it. If you are not sure also about the underlying diagnosis, don't cardiovert the patient. If it is elective, don't cardiovert without anticoagulation, proper anticoagulation. And if the patient also will not be sedated, don't cardiovert the patient if you can't sedate the patient. What about pharmacological cardioversion? Most of the time, pharmacological cardioversion, it's either if the patient is hemodynamically stable and it is for short duration, the atrial fibrillation, or if you are planning to start antiarrhythmic drug that to maintain sinus rhythm, and you are intending that to maintain sinus rhythm, and if it is for short, long duration, of course, you have to do TEE guidance and, of course, anticoagulation. This is the usual medication. Unfortunately, not all the medication is available. Amiodarone, I think it's available everywhere. Flecainide, butylide, propafenone, not available everywhere. What about pill-in-pocket approach? It's a really nice approach, but don't forget, first dose should be in the hospital to see the response of the patient. Okay, it's either you use the propafenone or flecainide, and of course, before you start, make sure that the patient has no sinus or AV node dysfunction, no bundle branch block, no major QT interval. If it is prolonged, you can't start it. If there is Borgata, if the patient is labeled as Borgata syndrome or structural heart disease, you can't start it. And the patient, before starting, should take beta blocker. Why? And this is very common in the practice and in the exam, because beta blocker or calcium channel blocker should be given to prevent rapid AV conduction in the event of atrial flutter. So if the patient has atrial fibrillation and you give antiarrhythmic propafenone or flecainide, the patient may develop atrial flutter. If the patient develop atrial flutter and the patient there is no beta blocker or calcium channel blocker, it may conduct all over the AV node to the ventricle. So beta blocker should be given before the start of pill-in-pocket. And of course, the first dose should be in the hospital. Should continue on beta blocker forever together with antiarrhythmic. It depends on the patient, most of the time, yes. If you are deciding pill-in-pocket, so the patient, because flecainide or propafenone can be taken regularly, not only pill-in-pocket. So it depends on your patient's situation, how frequent he develop the symptoms. For example, paroxysmal atrial fibrillation, the patient developed the symptoms once a year, once every few months, and you decided to give him pill-in-pocket. So of course, you don't have to give him beta blocker every day. But the patient, for example, has frequent symptoms, or he's decided that he will take flecainide every day. It's better to take beta blocker. Okay, I need your participation. Each question, one of you should answer the question. 75-year-old male patient, known case of coronary artery disease on aspirin, and latest echo showed ejection fraction of 45%. Okay, presented with shortness of breath, fatigue for 1 week. Blood pressure 140/89, heart rate 140, saturation is 96. This was his ECG. Who's going to answer? Please unmute. It's very easy questions. Don't worry. So this is atrial fibrillation with rapid ventricular response. Do you know the duration? No, we don't know the duration. The patient developed symptoms for 1 week and he's hemodynamically stable. So what's the next? Start amiodarone, start metoprolol, DC cardioversion, start flecainide, put him on oxygen. Who's going to answer? Someone, please. Unmute. B, start metoprolol. Yes, correct. Why? We don't know the duration. The patient is hemodynamically stable. And of course, his ejection fraction is impaired. So he will need beta blocker for even as part of his heart failure medication. The other options are incorrect. And yes, true. The next one, 43-year-old male patient presented with 2 hours history of palpitation, no past medical history. Blood pressure 96/60, heart rate 135, saturation is at 87. So before I go to the ECG and the question, the patient is hemodynamically unstable, right? So you know ahead of time that the patient will need DC cardioversion most likely, right? So this was his ECG. So atrial fibrillation with rapid ventricular response. What's next? DC cardioversion, IV metoprolol, oral amiodarone, start dopamine. What's the answer? Correct. DC cardioversion. So see, it's easy questions. 27-year-old male patient, medically free, presented with palpitation and dizziness for 30 minutes. Blood pressure 100/60, heart rate 190, saturation is 90. What's this? All of you should know this ECG. You will see it you will see it frequently in your life. In emergency, in the clinic, you will see it very frequent. What's this? In the exam, of course. Yeah, pre-excited atrial fibrillation. What to do for this patient? IV amiodarone, IV ismolol, DC cardioversion, digoxin. Which one? Of course, DC cardioversion. Unfortunately, I haven't seen it in myself, but 2 patients seen by my colleague. The patient presented with pre-excited atrial fibrillation, unfortunately given beta blocker, and the patient developed ventricular fibrillation. One of them unfortunately died. So it's very important to recognize the ECG, very important to manage the patient properly. Even if you don't know this patient, what's going on, the patient is hemodynamically unstable, just go for DC cardioversion. This was his ECG after cardioversion. Very nice, pre-excitation, delta wave, short PR interval, very clear, right? Okay, 52-year-old male patient, known to have diabetes, smoker, presented with shortness of breath, retrosternal chest pain, palpitation for 1 hour, blood pressure 130/90, heart rate 130. This was his ECG. What do you see? Procainamide is option, yes, but procainamide not available all the time. Not every emergency they know how to calculate the dose. Again, to be in the safe side, if you are in the emergency and you manage the patient hemodynamically unstable, just cardioversion. DC cardioversion. What do you see? STEMI and atrial fibrillation, right. What do you want to do for this patient? Ismolol, DC cardioversion, activation of cath lab, flecainide. Excellent. Activation of cath lab. Okay, done for atrial fibrillation. Any questions? You want to break? I can go. Okay. Palpitation and dizziness are the most common symptoms reported by patients with SVT. Chest discomfort may be secondary to rapid heart rate, and if a frequency subsides with the termination of the tachycardia. Persistent SVT may lead to a tachycardia-induced cardiomyopathy. History should include time of onset, triggers, any previous episodes of arrhythmia and the previous treatment. Detailed past medical and cardiac history is important. Patients who are hemodynamically unstable should be resuscitated immediately with cardioversion. ECG should be performed as soon as possible. Many patients with frequent episodes of paroxysmal SVT tachycardia tend to avoid activities such as exercise, just to avoid the symptoms. Okay, what's important for patients with SVT? It's always important to document. You can't treat something that you don't know. Even if the patient has recurrent palpitation, if it is recurrent, if you can't catch it with ECG, you can do Holter, you can do loop recorder, but of course, you have to document the SVT to decide about medical therapy. Okay, so if the patient has SVT, hemodynamically stable, the patient, it's either narrow complex or wide complex. If it is narrow complex, regular rhythm, yes, check for the P wave. If there is nice P wave, atrial flutter, atrial tachycardia, sinus tachycardia. If you can't see the P wave properly, it could be AV RT, sometimes atrial tachycardia. If it is irregular, and of course, if you don't see clear P wave, it could be atrial fibrillation. It could be multifocal atrial tachycardia. If it is wide QRS tachycardia, usually regular, it could be ventricular tachycardia. Irregular could be atrial fibrillation. And then you have to use the diagnostic criteria to differentiate VT or SVT. So investigation, ECG during symptoms and baseline, chest X-ray sometimes just to see if there is congestion, echo to evaluate for valves or other structural abnormalities. And don't forget, if the patient has recurrent symptoms, a lot of them, they develop tachycardia-induced cardiomyopathy if they reach to the hospital late. Monitoring devices, Holter, 14 days, loop recorder, ILR, and sometimes even nowadays, you can diagnose the patients with the Apple Watch because it can catch if they do it properly, you can view the PDF. And if it is, for example, SVT, it will be very nice. If it's atrial fibrillation, it will be very clear for you, very nice. So you can have the documentation. What's the differential diagnosis of wide complex tachycardia? VT, SVT with SVT with aberrancy, antidromic WBW. And if there is no P wave, if you can see the no P wave, it could be atrial fibrillation, sometimes atrial flutter with variable block, WBW, atrial fibrillation, polymorphic VTAC, TORSAD. When to consider WBW, AFib, when it's very ventricular, the rapid ventricular rate, wide QRS, bizarre QRS morphology. And of course, if you know that the patient has WBW or you have all the ECG with the pre-excitation. How to diagnose the patient when they have wide QRS? Check for first of all, if there is absence of RS complex in all precordial leads, V1 to V6. If it's yes, so then this is VT. Then check the initial interval from the RS to the end of the S. If it is more than 100 millisecond, this is VT. If there is AV dissociation, this is VT. If there is any of the morphology criteria for VT, again, it is VT. Burgadi criteria, actually, there is a lot of criteria to differentiate VT from SVT with aberrancy. Just try to memorize 2 or 3 and apply it and memorize it very well, apply it in your practice, so you will stick on it. Burgadi algorithm, if there is absence of RS complex in all precordial leads, yes, this is suggestive of VT. If the R to S interval more than 100 milliseconds in one of the precordial leads, yes, this is suggestive of VT. Then check for AV dissociation. If it is there, it is VT. Then check for morphology criteria for VT. And then you can say if it is VT or SVT. with aberrancy. What is the morphology criteria for VT? You check for V1, it's all in the precordial leads. If it is right bundle type, check V1. It's usually monophasic, only R wave. V6, either Q6 or QR. V1, if it is QR or RS, V6, usually RS, with small r, deep S. If it is left bundle, check the duration between the R wave. Usually, R wave is more than 30 milliseconds, and usually you see notched downstroke S wave. And usually there is QR or QS in V6. Major features to differentiate VT from SVT. What supports SVT? Slowing or termination by vagal tone, onset with premature P wave, PR interval less than 100 milliseconds, P and QRS rate and rhythm linked to suggest ventricular activation, depends on the atrial discharge. So you, for example, PAC. Long, short cycle sequence. What supports is VT? If there is a fusion beats, capture beats, AV dissociation, when the rhythm is depending on the ventricular activation discharge, if you see compensatory pause, if the QRS duration more than 140 milliseconds or 160 in some of the criteria, if there is left axis deviation or extreme axis deviation, absence of typical right bundle or left bundle morphology. You can check the rhythm here. Here you can see there is AV dissociation. Here you see that there is the QRS duration is very wide, and there is capture beat. Again here, this is a fusion. This is capture beat usually narrower than fusion. If there is positive or negative concordance throughout the chest leads, which I mean that it's entirely positive or entirely negative, this is suggestive of VT. Bourgade sign, as I mentioned, Josephson sign, this is the notch near the S wave. If there is RSR complexes with a taller left rabbit ear, which is different than right bundle. Right bundle, usually the first R wave is taller. Okay, again, this is I just want to show you here. This is how you measure from the beginning of R to the end of S. This is more than 100 milliseconds. This is S wave. This is the notch here. This is Josephson sign. And of course, sometimes from the scenario can say that this is most likely VT or SVT based only in the scenario before you go to the ACG. Why it's important to differentiate? Just to guide you for the correct management. Sometimes you have to use, to avoid special medication like verapamil, which cause hemodynamic collapse. Symptoms itself cannot guide you, but the scenario, the whole scenario, we're going to see later on, can guide you sometimes for the correct diagnosis. Okay, I need your participation. First, what do you see? Okay, it's easy. Again, it's very easy. What do you think about this ECG? It's very important when you read any ECG, even if you are a consultant or whatever, you take it to go to basic, because if you are confused, just if you stick the base to the basic, you will not forget anything. So it is regular. You can see very nice P wave and very nice QRS, and only the rate is high. So this is sinus tachycardia, correct. Thank you. Next one. You check the rate, rhythm, regular or irregular. Do you see any P wave? Do you see only one P wave? more than one P wave. QRS is narrow, so this is narrow complex tachycardia. And then check for the P's. What do you think? Check lead V1. Any idea? I know it's ECG is not perfect, but this is what you get in real life and unfortunately in the exam also. So it's better to practice bad ECGs. Atrial tachycardia, question mark. Yes, actually it is the atrial tachycardia. Why? There is P wave here, PR interval is short, so there is another P wave. And if you take the caliper and you check the P's, it's matching. So this is atrial tachycardia 2 to 1. Next one. Narrow complex tachycardia, irregular rate, right? Do you see P waves? Excellent, multifocal. Why? You see more than 3 actually different P wave morphologies. This is P wave, right? This is P wave. Sometimes it's upright, sometimes it's negative, sometimes it's not consistent. So this is multifocal atrial tachycardia. This one. Very clear, very nice. Regular, narrow complex tachycardia, P wave, upright in V1, more than one P wave, atrial flutter with very nice sawtooth appearance. Yes. Next one. Irregular, narrow complex tachycardia with no P wave. So, atrial fibrillation with fast ventricular response. Correct. Next one. Narrow complex tachycardia. Do you see any P wave? Junctional tachycardia. What is the rate here? SVT, yes, it is SVT. The topic is SVT, but at your level, you should know what, you can't say for sure it is 100%, what is this, but you have to know actually, SVT when you are internal medicine resident, but if you are cardiology fellow, now you have to be more specific. So this is AVNRT. Correct, AVNRT. AVNRT is more common than junctional tachycardia. You don't see clear P wave, but you can see what we call pseudo R, pseudo S, which is P wave, which is buried in the QRS. So this is AVNRT, okay? Again, it could be AVRT, it could be anything else, but this in this patient, this is AVNRT. This patient, this ECG is the same patient after ablation, sinus rhythm. Next one. Narrow complex tachycardia, no clear P wave. What do you think about this one? Again, it is SVT, but what is it? No, why flutter? Do you see any P wave? No P wave at all. You don't see any P wave, clear P wave. So you can say that it could be AVNRT or could be AVRT, right? It could be there is P wave here. No aberrancy, no, it is not, the QRS duration is not wide, so there is no aberrancy. So it is SVT, it is AVNRT or AVRT, okay? What is the difference between AVNRT and AVRT, or orthodromic AVRT? Actually, in the ECG, they may look the same. That's why the patient, they go for electrophysiology study. But sometimes that you can see some hidden P waves. The P wave usually, not like AVNRT in the QRS, sometimes it's a little bit away from the QRS, like here. So this most likely orthodromic AVRT. What is orthodromic AVRT? So for example, this is the AV node, this is the sinus node. Impulses supposed to go over the AV node. But if the patient has accessory pathway, the impulse will go over the accessory pathway and over the SA node. If the patient has conduction antigrade, like this, you will see in the ECG delta wave. But if there is no antigrade conduction, only retrograde, so the patient, baseline ECG will not see anything. But once the patient has SVT or tachycardia, they will have neurocomplex tachycardia with no clear P wave, okay? And don't forget WBW or pre-excitation. The pathway can conduct antidromic and can conduct what? Orthodromic. So this is the same patient actually. After termination of tachycardia, he has accessory pathway. This is nice delta wave with short PR interval. And the same patient, he is conducting antidromic. So he has here wide QRS tachycardia. Clear? So wide QRS tachycardia when the patient conducts antidromic, neurocomplex tachycardia when he conducts retrograde. And of course, the same patient can develop pre-excited atrial fibrillation when he go to atrial fibrillation, okay? Okay, next question, 70-year-old male patient. With a prior infarction, prior MI, had episode of syncope resulting in head laceration followed by spontaneous recovery, but persistent lightheadedness. So wide complex tachycardia, right? Who wants to contribute? Before looking to the ECG, from the scenario, the patient had MI before, so he has a structural heart disease. Again, it was real syncope. The patient fall in his face, he had head laceration. So before you look to the ECG, you have in your mind that you think it is most likely will be VT, right? So this is if you go to take the criteria, it is wide, more than 140 millisecond, wide QRS tachycardia. And if you go to the morphology criteria, this is RS morphology and with QR, suggestive of VT. What else? Yeah, so it is VT. Sometimes if you are, for example, if you are doing Holter and if you see only this, you don't know if the patient, this is wide complex tachycardia, is it VT or anything, SVT. But in Holter, you can see the beginning of the tachycardia. So you see there is P wave, P wave, P wave. So this is a flutter. Narrow QRS, P wave, QRS, narrow. And then the tachycardia started. So you know that this patient, this is not VT, this is SVT or flutter associated with bundle branch block, right? What about this ECG? Wide QRS tachycardia. but looks typical left bundle branch block, right? Do you see P wave? Look to V1. What do you think? يا سهل عليكم هذه. Yes, I know it's SVT with aberrancy. Correct, but more specific. Do you see P wave in V1? How many P waves you see in V1? I agree with you. Lead 2, lead 3, AVF, no clear P wave, but lead V1, very nice P waves. Excellent too. So this is atrial tachycardia with left bundle branch block. So it's true SVT with aberrancy, but you can be more specific, atrial tachycardia 2 to 1 with left bundle branch block. What about this one? سهل عليكم. Narrow-complex tachycardia, irregular rhythm, no P wave. So, excellent. Atrial fibrillation with inferior line. Why we have to treat atrial fibrillation properly? See this patient. He developed atrial fibrillation and then, unfortunately, developed 2 ventricular fibrillation. Okay, next patient, 42-year-old smoker presented to the emergency department with palpitation. His blood pressure was 100/60, and this was his ECG. ايش رايكم؟ Irregular, white complex, bizarre shape, QRS, yes. Don't forget it ever in your life. Pre-excited atrial fibrillation. 67-year-old male patient with history of previous infarct, reduced LV function, presented with palpitation, dizziness, blood pressure was 80/40. This was his ECG. Wide complex tachycardia. QRS duration is very wide, more than 140 milliseconds. So this is what? VT, صح? If you can take, if I want you to look to, yeah. سأوريكم بس. See this notch here? This is whether they call it Josephson sign. Okay, and if you take the measurement from R to S, more than 100 milliseconds. So this is VT. Okay, 80 years old male patient, feeling annual with palpitation. That's it. What's this? White complex tachycardia. More than 100 milliseconds, 140 milliseconds. This is, again, this is Josephson sign, okay? So this is ventricular tachycardia. And very nice here, very clear. If you take the caliper from R wave here until the end, it's more than 100 milliseconds, of course. So this is ventricular tachycardia. 45-year-old female. This was her ECG. ايش رايكم؟ QRS is not that wide, صح? And it looks more typical left bundle branch block. Rate is what, around 130? What do you think? Hmm? ها شباب left bundle branch block with okay SVT with aberrancy. Okay, because you don't see any clear P wave, I can't say for sure it's AVNRT or AVRT or atrial tachycardia, so acceptable to say SVT with aberrancy, but this is left bundle branch block. That's it. Any questions? Was it clear? Try to practice any of the criteria, try to look at ECGs as much as possible, because even if you are really good in ECG, the problem in real life and in the exam, sometimes you need to give the decision very quick, or sometimes in the exam you have very short time. So train your eyes to get the diagnosis immediately, just to save time. Okay, thank you. يعطيكم العافية. If you have any questions, you can contact me. شكرا.